This is our presentation on intraventricular grade 4 hemorrhages. In this presentation, we will cover all you need to know about intraventricular hemorrhages, including pathology overview, sonographic appearances, additional imaging, and outcomes. Pathology overview, intraventricular hemorrhage, description, etiology, incidence, and risk factors.
Description. Grade 4 intraventricular hemorrhage is also often referred to as periventricular hemorrhagic infarction, PVHI, or intraparenchymal hemorrhage, IPH. This is considered one of the more severe forms of intraventricular hemorrhage as it affects the parenchyma of the brain. For background, grade 1 is when bleeding from within the germinal matrix that does not extend past the caudothalamic groove. Grade 2 intraventricular hemorrhage will occur when the hemorrhage extends to the ventricles. However, there is no associated hydrocephalus. Grade 3 hemorrhage is also considered severe and is associated with when hemorrhage occurs into the ventricles with hydrocephalus present. Grade 4 intraventricular hemorrhage is hemorrhage that affects the brain parenchyma outside of the ventricles. Grade 4 intraventricular hemorrhage usually affects the frontal and parietal lobes of the cerebrum, with the parietal being the most common at 51%. The hemorrhage may occur unilaterally or bilaterally. However, unilaterally is more common. If there is bilateral hemorrhage, then it's more likely to be asymmetric. There can be progression from intraventricular hemorrhage to periventricular hemorrhagic infarction within 1 to 3 days. The diagnosis of this will often be done using neonatal neurosonography to assess for abnormalities like clots outside the ventricles. The use of neonatal neurosonography is the primary modality used to first assess for this condition. To confirm periventricular hemorrhagic infarction, MRI may also be used. This will be further discussed in the rest of our presentation. Etiology. The cause is thought to be by hemorrhagic venous infarction just above the caudothalamic groove. This occurs because the basal ganglia's deep draining veins are obstructed, which causes the venous infarction. Intraventricular hemorrhage often initially occurs between grade 4 intraventricular hemorrhage or periventricular hemorrhagic infarction. If there is severe intraventricular hemorrhage, then ischemia may occur, which will eventually cause infarction, and the blood will hemorrhage into the surrounding tissue. Grade 3 intraventricular hemorrhage is associated with hydrocephalus, which is a potential cause for why the veins could be compressed. It is shown that grade 3 intraventricular hemorrhage is closely associated with periventricular hemorrhagic infarction. Figure 1 shows a diagram of where the hemorrhage occurs and where there is ischemic damage, causing the hemorrhage to go to the surrounding tissue. Incidence. The overall incidence of intraventricular hemorrhage is 25% of preterm infants, and about 10 to 15% of those neonates will demonstrate periventricular hemorrhagic infarction. If the neonate is underweight, under 1,500 grams, or has low gestational age, under 32 weeks, the likelihood of developing severe intraventricular hemorrhage increases. The likelihood of severe intraventricular hemorrhage was more prominent in infants under 28 weeks or less than 1,500 grams, at 11% having severe intraventricular hemorrhage, which would include periventricular hemorrhagic infarction or grade 4 intraventricular hemorrhage. They found with infants between 28 to 32 weeks, the incidence of severe intraventricular hemorrhage decreased to 5%. This shows the importance of being aware of the gestational age of the neonate to further evaluate the conditions that they may be susceptible to. The higher the grade of intraventricular hemorrhage, the more likely it is to become periventricular hemorrhagic infarction. So grade 3 intraventricular hemorrhage will have the highest risk of progressing to periventricular hemorrhagic infarction. In a study done by Sismecki et al., they found that 84% of the cases they studied had patients with grade 3 intraventricular hemorrhage, in addition to periventricular hemorrhagic infarction. Risk factors. So the key risk factors are a low gestational age, generally under 28 weeks are highest risk, and then also a low birth weight at less than 1,500 grams. Other risk factors overlap with this. Preterm infants are underdeveloped and they have associations with a lot of other conditions and other factors for their birth. So I have a list here. I'll go through some of them, but I won't read all of them. So other things include thrombophilia, patent ductus arteriosus, lack of antenatal steroids, seizure, multiple pregnancies, maternal hemorrhage before delivery, respiratory distress syndrome, early prolonged fetal stress, maternal chorioamnionitis, early sepsis, hypotension requiring intervention, and more.
Sonographic features of intraventricular hemorrhage, normal and abnormal appearances. Majority of our images were taken using Mohawk's Sonita system. In this imaging simulation, we are able to practice scanning neurosonography on a NICU patient. There are simulations of normal anatomy and pathology, such as intraventricular hemorrhage. A limitation in this technology is that we are only able to scan through the anterior fontanelle. Using Sonita, we will discuss our normal scan routine and the anatomy relevant to detecting hemorrhage. Starting with the coronal images, our first image is of the most anterior part of the brain. When scanning, we look at bony landmarks to help guide us. The grooves of the orbital recess verify that we are indeed in the frontal lobes. Here we can assess the symmetry and integrity of the white and gray matter. The symmetry of the bones help confirm true asymmetry caused by pathology and not the sonographer obliquing the probe. The falx is seen separating the right and left frontal lobes. Angling posterior now shows the anterior horns and basal ganglia. Choroid plexus tapers off at the germinal matrix and therefore is never seen in the anterior horns. In this image, we can start to see evidence of severe bleeds such as grade 4 hemorrhages, extending to the anterior horns. Other anatomy seen is listed on the slide. This includes the frontal lobes, falx, cingulate sulcus, corpus callosum, lateral ventricles, specifically the anterior horns, caudate nucleus, CSP, sylvian fissure, insula, stella tertia, and temporal lobes. A landmark used for this image is the stella tertia, an elevated area of the sphenoid bone, which also marks the level of the circle of Willis. In Sonita, the sylvian fissure is closed, as she is a term baby. Going more posterior, we have the area of the caudothalamic groove and short axis. This is where the germinal matrix is found, which is an important area to image when hemorrhage is suspected. As sonographers, we carefully assess symmetry between the ventricles here. Measurements are taken at this level. AP width of both anterior horns, the ventricular index, which is the distance between the most lateral part of the ventricles to the falx, and the width of the third ventricle quantify our search for symmetry. Continuing posteriorly, the next coronal image shows midbrain and posterior fossa. Although our focus is on intraventricular hemorrhage, this view could help us identify any cerebellar bleeds, as well as asymmetry in the choroid plexus and ventricles. The bulk of the choroid plexus is seen in the antrum of the lateral ventricles, an area usually abnormal in grade 4 intraventricular bleeds. Again, other structures seen are listed on the side of the slide. The next coronal image shows the classic starman appearance of the echogenic quadrigeminal cistern. Extending from the base of the star on either side is the tentorium, the roof of the cerebellum. Now we are too posterior to see caudate nucleus, so we only see thalamus under the lateral ventricles. Posterior to the cerebellum, we see the bulk of the choroids. In preterm infants, it is important to note that the ventricles will look larger due to the cerebellar tissue to ventricle ratio, and we should not call bleeds until checking the corrected gestational age of the patient. Another pitfall is the white matter around the ventricles. It is important to look at echogenicity increase in case that there has been a hemorrhage that has spread. However, we must also assess size and symmetry of ventricles to make sure that we are not calling normal white matter a hemorrhage. In the most posterior image, we are now out of the ventricles showing the occipital lobe parenchyma. The deep white matter, called the centrum semiovale, is the echogenic area in the cortex. In this view, we assess for extending pathology from the ventricles, such as intraventricular bleeds. We must differentiate from the normal centrum semiovale. The classic midline sagittal image shows many structures listed on the side of the slide. The frontal, parietal, and occipital lobe parenchyma is assessed. Corpus callosum and cingulate sulcus are seen as normal evidence of migration. In Sonita, the cavum virgae is closed. Only the anterior CSP is open. Third and fourth ventricles, as well as brainstem, are seen. The elevated sphenoid bone that was used as landmarks in our coronal images can be seen here in long axis. Inkling slightly lateral from the midline sagittal image, we see the area of the caudothalamic groove. The area of the germinal matrix is located between the caudate nucleus and the thalamus. This area is critical for seeing hemorrhages in abnormal shape of the choroid plexus. This view shows the most lateral parenchyma. This is the view of the sylvian fissure and how we would assess the middle cerebral artery within it for pulsations. But we can look for any intraparenchymal hemorrhages that is spread to this area.
A grade 4 intraventricular hemorrhage is characterized by the presence of interventricular hemorrhage along with interparenchymal hemorrhage, which may or may not be accompanied by hydrocephalus. The interventricular hemorrhage appears on ultrasound as an intensely echogenic, mass-like lesion, and its irregular margins will be difficult to distinguish from that of the walls of the lateral ventricle. Grade 4 interventricular hemorrhage is most commonly found in the frontal and parietal lobes unilaterally, with bilateral cases being asymmetrical. On color Doppler, grade 4 interventricular hemorrhage will display absent flow in the subependymal veins. Interparenchymal hemorrhage is secondary to interventricular hemorrhage. Interparenchymal hemorrhage is not an extension of the interventricular hemorrhage, it is a result of ischemic injury to the periventricular white matter. It appears on ultrasound as an echogenic, mass-like lesion with irregular margins in the parenchyma adjacent to the ventricle. In its early stage after onset, it's unattached to the ventricular wall. In a later phase, it may merge with the ventricular wall to form a larger hypoechoic lesion or remain separate. It's not until a later phase, approximately 2 weeks, where the interparenchymal hemorrhage will become hypoechoic as it begins to liquefy. This image demonstrates a later stage of grade 4 interventricular hemorrhage, where the ventricular walls are indistinguishable from the hypoechoic interparenchymal hemorrhage. The mass of the interparenchymal hemorrhage is causing a midline shift towards the left hemisphere. Grade 4 interventricular hemorrhage in a 22-day-old infant born at 23 weeks gestation with a history of interventricular hemorrhage and ventriculomegaly. A. Coronal image showing heterogeneous echogenicity in the left ventricle caused by interventricular hemorrhage, and right periventricular and interventricular echogenicity of the germinal matrix caused by interparenchymal hemorrhage. B. Sagittal image of the right lateral ventricle. C. Sagittal image of the left lateral ventricle.
The posterior fontanelle offers a better visualization of the choroid plexus and occipital horns of the lateral ventricle. This is an image by Huang et al. Showing a parasagittal view of normal anatomy through the posterior fontanelle. This view clearly demonstrates choroid plexus and occipital horn. An advantage of scanning in the posterior window is the elimination of blush artifact. In the peritrigonal region, where the white matter tract lies, scanning through the usual anterior fontanelle sends in sound waves at a directly perpendicular angle to this area. This causes high reflectivity of the axons and glial cells, which increases echogenicity. Sonographers must rule out potential hemorrhages when looking at an echogenic area. We can see if this artifact is eliminated in the posterior window, as we are now sending sound waves in at a parallel angle, and therefore ruling out hemorrhage. The posterior fontanelle will demonstrate the progression of bleeds into the occipital horns. Since our transducers are closer to the choroid plexus, we can see details of heterogeneity of the bleeds in the ventricles with better resolution. This is an image by Correa et al. That shows intracranial hemorrhage through the parasagittal image taken in the posterior fossa. Enlarged choroid plexus with heterogeneous echogenic area is seen. Additional imaging for intraventricular hemorrhages, MRI versus ultrasound. Ultrasound stands out in terms of accessibility. We do portables and come to high-risk patients without disturbing them from their environment. Our scans are cost-effective and quick. For neonates, we use high-resolution, small-footprint transducers to provide detailed resolution. A hemorrhage as severe as grade 4, along with the age of the clot based on the echogenicity patterns, will differentiate that from normal tissue contrast. There are pitfalls that sonographers should watch out for when looking at the spread of echogenic hemorrhages. It can be hard to separate the contrast of white matter or any artifacts such as blush artifacts from the bleed. Compared to MRI, the resolution is less, which can decrease sensitivity, especially for smaller hemorrhages. Lastly, as the baby grows, the fontanelles will close and our scan windows will become progressively smaller. After 12 months, ultrasound can no longer access our scanning windows. MRI has high contrast resolution. superior to the level of ultrasound. In MRI, radiofrequency pulses are sent into the body. The sequence of these pulses can be manipulated to produce differently weighted images in terms of contrast. Each weighting means that we can visualize hemorrhages in different ways. Most commonly used are T1, T2, and flare sequences. The stage of hemoglobin breakdown also produces a different appearance, allowing MRI to detect the age of the bleed. MRI shows a volume of the body and allows us to get the big, broad overall picture and visualize the bleed extent. MRI is expensive, time-consuming, and not accessible. A NICU patient may be unable to come down to the imaging department depending on what equipment they are hooked up to. Depending on the level of activity of the patient, they may need to perform sedation so the infant can stay perfectly still for the scan. The T2 sequence weighting cannot detect the age of the bleed. Flare sequences is the best option to suppress the CSF signals, allowing for better details of the hemorrhage to be visualized. These images are by Huang et al. In image A, we have a coronal ultrasound image showing asymmetric enlarged right choroid plexus, seen with the white arrow. Echogenic heterogeneous appearance showing intraventricular hemorrhage. B and C are both axial MRI images. B shows blood product as bright on T1 weighting sequences, and C shows the same blood product as dark on a susceptibility weighted sequence. Overall, this shows the variability in how we can view hemorrhages in MRI, and the higher contrast resolution compared to ultrasound. Despite the higher contrast resolution, ultrasound should continue to be the first line of imaging with suspected intracranial hemorrhages. Outcome and follow-up of intraventricular hemorrhage, progression, treatment, and outcome.
The interventricular and interparenchymal clots will liquefy and retract approximately 2 to 4 weeks after onset of the grade 4 interventricular hemorrhage. This will appear on ultrasound as a mass with irregular echogenic margins and a hypoechoic center. Following this, encephalomalacia will develop 2 to 3 months after interventricular hemorrhage. Encephalomalacia is a cystic mass of destroyed brain tissue lined with gliotic white matter and reactive astrocytes. Encephalomalacia masses contain septations and they may communicate with the ipsilateral ventricles and residual interventricular clot. 1/3 to 1/2 of infants with interventricular hemorrhage develop post-hemorrhagic ventricular dilatation. The trigones and the occipital horns of the lateral ventricles are first to dilate. However, with PHVD, the entire ventricle will appear dilated, displaying its characteristic ballooning appearance. The third and fourth ventricles will dilate last, however not as severe as the lateral ventricles. Chronic hydrocephalus will occur after interventricular hemorrhage due to obliterative arachnoiditis, causing obstruction of the cisterns, obstruction of the fourth ventricular outflow tract, or an interventricular blockage due to clot, septation, or debris. Signs and symptoms of hydrocephalus secondary to interventricular hemorrhage include increase in head circumference, bulging of the cranial sutures, stupor, vomiting, or ocular changes. 40 to 50% of infants develop progressive dilatation, however, this will likely resolve within 4 weeks of onset. Every center has their own ways of measuring the ventricles to assess for hydrocephalus, some of which may include the lamo-occipital distance measured in the sagittal plane, as well as an anterior horn width and bitemporal diameter measured in the coronal plane. The third and fourth ventricles are also measured in both the sagittal and coronal plane to obtain the width and the AP diameter. There are no current treatment options for grade 4 interventricular hemorrhage. However, the post-hemorrhagic ventricular dilatation and subsequent hydrocephalus does require treatment. 25 to 35% of grades 3 and 4 interventricular hemorrhage require shunting as a means of treating hydrocephalus. There are several different treatment options for hydrocephalus, some being temporary while others are permanent. Temporary options include ventricular access devices, external ventricular drains, and subgaleal shunts. External ventricular drains are placed into the right lateral ventricle via a hole in the skull and allowed to drain outside the body through a catheter. The exact location is determined by the surgeon, however, the frontal horn of the right lateral ventricle is most commonly used. In cases of asymmetrical hydrocephalus, the proximal shunt is placed in the larger of the two ventricles. A subgaleal shunt is used when the infant cannot tolerate another temporary shunt. A pocket is created in the subgaleal space between the skull and the skin, which collects the CSF from the ventricles. This collection creates a fluid-filled bulge on the infant's head. While these solutions offer temporary relief, an average of 70% of infants become dependent on ventricular shunting and require permanent solutions. Ventricular peritoneal shunting directs the CSF collected from the ventricles into the peritoneal cavity via a catheter. This catheter can also be directed to the heart, called a ventriculoatrial shunt, or rarely to the ureter or bladder. Repeated neural sonography is also required to monitor ventricular size for a minimum of 4 weeks after the onset of intraventricular hemorrhage. Rates of morbidity and mortality heavily depend on the degree of intraventricular hemorrhage, prematurity of the infant, and progression of the hemorrhage. The mortality rate for grade 4 intraventricular hemorrhage is 22 to 45%, while 75% of surviving infants will have lifelong motor and intellectual deficits, and 50% of surviving infants will develop cerebral palsy.